Great. Thanks, Aaron. You're doing a great job. And I had a great time with the teenagers, moms and dads out there. You have amazing kids. I know that. I've had a privilege of taking care of hundreds and hundreds of them over the years. And the group that joined us were no exception. Except, one of the kids had a Green Bay Packer sweater on. And I'm from, Rochester, Minnesota. So like Vikings, I know we're terrible this year, but still, but it's okay. My girlfriend, my girlfriend, that got me in trouble. My daughter is dating a guy, great guy, but he's a Green Bay Packer fan. So that's okay, Presley. Presley's great. Well, I love the fireside chat time. I want to thank again Dr. Susan Etheridge and Dr. Prince Canackerel for their lectures. I've heard Prince before. I know they're great. Susan's are always great, but I got to hear her. So I love spending the morning with you all listening to that. Again, want to thank our corporate sponsor for the conference, Invitae, and our afternoon session sponsors, Ambry Genetics and LifeSure. I'm on the WOVA thing, so I'm double duty. So I'm looking at you via Zoom and got your questions on WOVA, and if I'm saying that right, and we're just going to go. So fasten your seatbelt. I haven't gotten to preview them, so we're just live and spontaneous, and we're going to take them in order as they're popping up here. 8 votes for Sophie's question. And then there's a Dana doing a hand raise. Dina, I'm not going to be able to see that hand raise thing, I don't think. I don't think that chat function on Zoom itself works. So here we go. Sophie, great question. 8 votes. Is treatment available to reduce the negative side effects, i.e. extreme fatigue of beta blockers? It's a great question. I get this asked all the time, and I know Dr. Etheridge was posed that and started to answer it as well. I would say, first of all, most patients, at least 2/3, the beta blockers agree with them beautifully or acceptably, meaning you're pleased, and if you're pleased, then I'm pleased. But we at my program here at Mayo Clinic, we get a skewed perspective of beta blocker side effects because I tend to see an enrichment of patients who are dissatisfied with life on beta blocker. They're my self-declared beta blocker zombie. Their term, not mine. I just share it with you. And that's the person who says, we've traded a disease called long QT that might do something awful in me, but usually not because it's well treated. But we've traded it with a new disease called I feel lousy every day from my beta blocker. Thank you very little. And if that's you, just know that you're not alone, that there are strategies that we can use to try to make that less. So for example, one of the biggest mistakes I see out there is taking an adult patient, low risk, never ever a symptom, and then the next day putting them on slug a dose of Nadolol, 60 milligrams a day right away. So went from 30 years as a beta blocker virgin to next day, bam, 60 milligrams of Nadolol. That's a surefire way of making you a beta blocker zombie and hitting you over the head with the fatigue effect. So we on our end can do it much wiser where we take our time. And in a low-risk patient who we had diagnosed in adulthood, it might take Dr. Etheridge and Dr. Canackerel and myself 2-3 months before we get to my goal dose, not 2-3 days or 2-3 hours. So I think we have inadvertently contributed to the fatigue problem, we meaning the community of healthcare providers, by doing it the wrong way. But let's say we do it the right way and you still don't like beta blockers. What can you do about it? Well, one, you can stay at it. Don't give into it. Stay active. Don't just become lethargic and create that negative spin cycle vortex of doing less, eating more, doing less, eating more, doing less, and then spiral down into this fatigue package. Now, let's say you're doing all of that, positive attitude, trying your best, and I'm just the zombie from the beta blocker. First, never resign and say, I guess this is my lot. I guess this is how I get to do life from here forward. Don't do that. We have too good of treatment alternatives to counter that. It might be trying a different beta blocker. It might be scrapping the beta blocker altogether and going over to left cardiac sympathetic denervation. I currently have about, I'm not sure now, 50, 60, 70 patients who we have on denervation solo therapy, meaning one-time treatment, their denervation, and we brought their natal law down from 60, 50, 40, 30, 20, and sometimes down to 0. And so the point being is we have options. We didn't used to have options 20 years ago. It was sort of beta blocker or bust. And we made you beta blocked, and those who became the beta blocker zombies, so be it. So be it is not acceptable any longer. We have way too many options to explore. So stay in there, stay strong. If quality of life is good, great. If quality of life is not, seek more. SADS Foundation to live and thrive despite your condition. Sophie, thanks for the question. Next highest vote right now is from Amy, 6 votes. Is there any research updates on rechargeable batteries for ICDs so we don't need replacement surgeries? Not here yet. Futuristic. I don't know when that future is as to when we'll have the body itself be able to recharge the battery from the electricity that we generate in our body and then harness that and have that charge the battery. People are working on that, but we're not there yet. So for now, what we have is knowing that the ICD battery of today lasts a lot longer than the ICD battery implanted 10 years ago. So we are gaining years with the improvements in each ICD generator. Now, the standard ICD, if implanted here, typically will have about a 12-year battery life. So will we ever have a rechargeable one? I bet. Will it be before I retire, 20 years? I think so. 6 votes. Again, Sophie, are there any research projects about other methods of treatment besides the beta blocker? Not really research projects because we have great standard clinical therapies besides beta blockers. But are there research projects for non-beta blocker medication strategies? Absolutely. That's some exciting news. There's a company out there, LQTS Therapeutics, that is working on novel medications, compounds to treat long QT that are not beta blockers. Our program at Mayo Clinic is very active in novel therapies for long QT and CPVT, including gene therapy. And we've got some exciting progress there, hopefully a paper to come out soon. Still a long ways away from making it to you as a bona fide treatment, but people are actively working on that. Is research being conducted, Sophie asked, on the role of food or diet to prevent episodes? Not so much being conducted because there's really no foods or diets that are QT dangerous, except I would say rapid weight loss programs, liquid protein starvation type diets are not long QT friendly. These can cause electrolyte fluxes, tendency to drop your potassium. Remember, low body potassium, hypokalemia, is not a friend to long QT. But there are other things that we have debunked long ago. How many of you have been told, raise your hand, no chocolate, as if chocolate is QT dangerous? Chocolate is QT nonsense. There's no concern about chocolate or caffeine in moderation. So not too much on that front. Great question. Another one from Amy, 4 votes. Is there any research being done as to why does the de novo spontaneous mutations occur? That's being done in general across medicine. We know that in our diseases, about 90 to 95% of mutations are heritable, meaning if we could trace it back, the mutation would be there. About 5 to 10% start new in you as a de novo mutation. That de novo rate is slightly higher in CPVT than it is in long QT syndrome, for example. 3 votes. Amy, I was diagnosed with long QT initially, then many years later got re-diagnosed with CPVT. I've known a few others who were also diagnosed with long QT at first. Why does this occur? We see this all the time, Amy. We first published this many years ago now about the incorrect diagnosis of or misdiagnosis of CPVT as long QT syndrome. Part of that is because the familiarity about long QT is greater than CPVT. So CPVT is less understood. And you saw from Dr. Etheridge's talk that the story can be very similar, meaning the story of CPVT and the story of LQT1 are very similar. Exercise triggered fainting, exercise triggered seizures, and so forth. And so the story, because people are more suspicious with long QT, start thinking long QT first, if they're thinking correctly at all. Then you get an ECG, and the ECG is normal. That should be your first hint that it's not long QT. But because people are more familiar with long QT, they say, I think this might be the normal QT interval long QT thing, which does exist. It's just that symptoms from that version of long QT are incredibly uncommon. And so had they been thinking correctly, they would have then shifted you over to a treadmill stress test to get the aha moment that Dr. Etheridge showed with the abnormality brought out during exercise. But your story is not uncommon. We see this a lot. Susan, great question. What's the current treatment for newborns possibly diagnosed with CPVT? Well, in newborns who are tested with CPVT, because of the family story, maybe the CPVT1 mutation in the ryanodine receptor has already been found. So now the baby can get cascade tested to find it and show that it's there. Then if the baby owns it, the CPVT1 mutation, the genetic variant, then we can start the baby on prophylactic beta blocker therapy, either liquid nadolol or liquid propranolol. That currently is the standard convention throughout the world. Positive genetic test, because of the family cascade test, start the baby on liquid beta blocker prophylactically. Some of us are looking at other strategies, including monitoring the baby with a Holter, the 24-hour ambulatory ECG, knowing that baby's life during that 24 hours is kind of their stress test. And as long as there's no CPVT ectopy, skip beats recorded, maybe we just continue to watch and wait and not start the baby on liquid beta blocker. That currently is an approach that we offer to the families, and we've been pleased with that non-treatment observation strategy. But for the most part, the international guidelines say baby tests positive for the family genetic marker, baby gets started on liquid beta blocker. Nicole is asking, what is the statistical likelihood that an asymptomatic high-risk LQT2 patient will have a breakthrough on beta blockers alone? Wow, that's a good one. So I'm assuming that the LQTS2 patient, there's what's important to answer that is there's a lot of things I need to know to be able to tell you what that likelihood is. Are you an LQT2 girl or boy, man or woman? How many asymptomatic years do we have under our belt? And then why are we being called high risk? Are we being called high risk because your QT is really long, or are we being called high risk incorrectly because a cousin died from it? In other words, family history, bad, tragic, really sad, but not a risk factor to you. So on what basis are we being called high risk? And then that can help me decide how confident I am with beta blocker solo therapy. So an asymptomatic LQT2 man, I'm really confident that beta blocker alone is all we need. An asymptomatic LQT2 30-year-old female whose QTC is 550 milliseconds at rest, I'm not confident enough in beta blocker alone. And for her, even though she's never had an event yet, I will be intensifying her treatment program with more than just beta blocker. I will be doing beta blocker and mexiletine. I'll be doing beta blocker and potentially denervation. I will be doing potentially an implantable defibrillator as a preemptive move, because of all of our asymptomatic individuals with long QT syndrome, the single highest risk subset would be asymptomatic females after puberty whose QTC is above 550, even 530. So we need to respect that subset a lot. What are the risks? Great question, Nicole. Eliana, 3 votes for what are the risks with denervation surgery, percentages of risk for phantom pain, facial nerve damage, etc. Well, that's a great question. There's a lot, I would say, misinformation out in Google land, because those individuals who had a denervation and they're getting along beautifully, they're not Googling. And so they're back doing all they want with not being a beta blocker zombie anymore, for example, and loving life. We know that overall, we published this, and Jonathan Skinner's group down in New Zealand also published quality of life after denervation, and the quality of life scores are really high. I think it was something like 90 to 95% of the patients said everything they know after their denervation, they would still go ahead and do the denervation all over again. That's really high. Now, it is surgery, and so it is not risk-free. And so some of the things that are expected sequelae, consequences of removing the nerve, include your left hand will be drier and warmer than your other hand. The left side of your face will sweat less than the right side. That's expected. That's not a risk or a complication. That's a fact of removing that chain of nerves. Now, the facial nerve damage, that's like 0. So you don't have to worry about that if it's done correctly. The notion of a left-sided droop, that's 0 in our program for 15 years now. The droopy left eyelid, that's about a 3 to 5% chance. We've done 1 eyelid lift surgery in our first 300 denervations. Now, again, part of the risks are going to depend on where you have the denervation done. Surgery is surgery, and those who have the best boutique operators will have the best results. That's just true of any surgical center. That experience matters and volume matters. And so thankfully in our program at Mayo Clinic, we have done more denervations than anywhere in the world. So I think we have a handle on what are all the possible risks. And I think our risks are probably the lowest because of that experience. Now, the one risk that you mentioned, Eliana, is really important, phantom pain. I'm not sure I would call it phantom pain like it is with if you've had a knee amputated and you feel pain in that part of the body that's not there. That's sort of phantom pain. What you're really referring to is what we call the post-denervation neuropathic pain. And that's a pain that emerges in about 5 to 10%. It's a real 5 to 10% from the cut ends of the nerves down at T4 where the resection starts and up at the stellate ganglion. The nerves left behind, they're ticked off and they need time to heal. And for most of us, that healing process is a nothing. It's easy. It's really going on in the background and the patient doesn't care about it, doesn't notice it. 5 to 10%, it's a real whopper of neuropathic pain. And the good news is it goes away. Bad news is it can take weeks, months, and I've had one patient where it took up to a year for it to finally melt into the woodwork. And for that time, those patients who are on the receiving end of the neuropathic pain, they're not happy campers. They actually don't probably like me during that time period while they're doing it, and they're weighing in the balance. Would I rather have been the zombie or this neuropathic pain? Once everything is settled, those who are able to move on, and there is a battle of the mindset to it as well, they're glad they did it. So we are working hard to try to figure out why is it that 5 to 10% who have it and the 90% don't. What are some features? We have some insights. Those who have had a tendency towards chronic fatigue setup, fibromyalgias, other types of pain syndromes, they're more likely to react to this nerve surgery and be part of that 5 to 10% with the neuropathic pain. Here we go. For CPVT, why is it that I get VT during the time I am sleeping? Uncommon. Most often CPVT events happen from noon to midnight, not midnight to noon overall, happen during exertion. But in some patients, it happens during sleep. And that's in part because sleep is not a adrenaline-free experience. So there are night terrors during sleep. We know about REM sleep and non-REM sleep. So the notion that sleep is a period of time when there's not much adrenaline or epinephrine throughout the night is simply incorrect. And so it could be the possibility of that. Melissa is asking with 3 votes, have you heard of elevated stress levels from everyday issues, work, family, life, COVID, trigger an episode or an ICD shock? Melissa, I love this question. It's an important one because there was some studies done quite a while ago. I'm blanking on the name of the psychiatrist in Arizona, great guy, that looked at sort of your persona, if you will, and whether our persona weighed into making us more susceptible. In other words, there's an impression that I and others have had over the years that those of us who are in our, constitution, Hakuna Matata from Lion King, no worries, a trouble-free philosophy, cool, calm, and collected, might be more protected. Whereas those who are more jazzed or jittery or reactive, if you will, they may be more vulnerable. And there's some studies going on, not in long QT per se, but in like atrial fibrillation and other heart rhythm conditions where mindedness and centeredness and rhythm breathing and sort of those meditation and things like that to sort of ground you, center you, may be an antiarrhythmic therapy, protective, preventative. And so there's definitely stuff there. In many of our long QT patients, CPVT patients, when they had their shock, it wasn't as if life was perfect and then suddenly, boom, it happened. Many of them will share a story that they were just off the day before, that there was unique stress meter changes. And so I think you're onto something there, Melissa. Certainly we've seen it. And we have, in fact, patients who've had multiple recurrent therapies have suggested, let's be intentional with a cognitive behavioral therapies, breathing apps to just try to help bring that strategy in place. Andrew's asking, with CPVT, is it commonplace to have inconsistent symptoms during exercise or emotional upset? He found that before taking his Nadolol, good job for your doctor, that exercise and upset didn't always do it, but on other occasions it did. Well, that's perfect, Andrew, because if exercise and emotion always did it, we would be always having an event. So that's sort of the gazillion-dollar question for long QT and CPVT, where it's adrenaline triggered, emotional triggered. Why that day? Been training, running for years, but why that day did the faint occur during that run? I've had emotional outbursts before, but why did that emotional outburst trigger my faint? So it really is, we know kind of what loads the gun, the genetics loads the gun, but the environment, the constitution, the Hakuna Matata, all those things like a perfect storm pull the trigger. And we haven't figured all of those elements out very well, but there's definitely going to be a story there that will come out. Some of these are long questions, so I apologize. So if I get to other ones, try to be really, as they say, pithy, so that I can read them quickly. But here we go. Juliana, if you have long QT, is there a way to know that your medication might need either a different dose or change altogether? Not sure if my doctor would check into changing medicines. I also have AFib, so don't know if I'm tired for all of that. Yeah, I think Susan, Dr. Etheridge pointed that out, that anytime we assess your risk, based upon that risk forecast, I sort of have a goal dose in mind that I think would get us to reasonably protected, because I don't want to pseudo treat you and put you on a whiff a dose and call that treatment. We either need to install treatment or not. And we have a dose in mind, and we look at things like, how are you doing with it? How is your stress test responding to it? Can I measure a measurable effect that I've got beta blocker circulating in the system? And often we will up titrate until I encounter what I call the maximally accepted dose, or the MTD, the maximum tolerated dose, because it doesn't matter what dose I have in mind if I get you to a dose and I've given you a new disease called, thank you very much, I'm a zombie now. So we look into all of that, and we're very particular in trying to dial in the right dose for you. So even in beta blockers, we try to practice what Dr. Etheridge called precision medicine. Rachel, for people who didn't like the beta blockers and got the denervation, are there any new findings about reducing the side effects from surgery? She had it a little over a year ago and have had pretty constant chest pain with intermittent stabbing chest pain since. Looking for ways to reduce it aside from injections and pain meds. I've tried both. So Rachel, first, sorry that you're on the receiving end of that 5-10% phenomenon. It really becomes, it's a frustrating, and you certainly probably are going through that frustration of this chest pain sensation that you have. I think the first thing is to make sure that there's nothing else going on, because typically in post-denervation neuropathic pain, the pain of the neuropathy, if you are that subset, it is the spot right there, and then down here and down here. There's really not the pain over the chest itself per se. Now, everybody's innervation pattern is different, and so anything is possible. I think part of what we're learning, and you did probably get to receive it, is we jump on that pain way quicker than what programs did years ago, so that if that person's declaring him or herself as being the neuropathic pain, we're starting to get the nerve healing medicines, gabapentin, and so forth on board sooner. And I think that has made a difference to short circuit it and bring recovery faster. In those who are already past that window of opportunity, like yourself, I think it's really working with your healthcare team, working with the pain specialist, not waving the white flag. Try to get as active as you can so you get your mind to sort of focus on something else, because the mind is a beautiful thing. It's also one of our biggest enemies that sort of gets locked in on that pain phenomenon, and then sort of the world gets centralized down there. And if we can break that centered focus and get centered on living again, then we can win again. Not easy, and I wish you the best with that. Eliana is asking, these are great questions, by the way. I think we're doing rapid fire and we're 30 minutes in, and I'm just scrolling down. So I don't know how far we are and what new ones are going to come, but these are awesome. I love this. I hope you like this. Oh, somebody just got outvoted there. I did that one. Okay. Here we are. 2 votes. With CPVT, if one has frequent PVCs at rest on natal and flecainide, is denervation useful, or is it mainly for exertional arrhythmias? Well, first of all, that's a great question, Nancy. Second, frequent PVCs at rest might, and I emphasize might, mean that that's not your CPVT. In other words, some CPVT patients can have 2 things. True CPVT arrhythmias are those where the ectopy is not there at rest and then comes out at a heart rate of about 115, 120, 125, progresses like Dr. Etheridge showed you, and then peaks out at peak, and then in the recovery phase, perfect again. Now, there are some patients who have resting PVCs who don't have CPVT at all. And so it stands to reason that there are going to be some CPVT patients who have both ambulatory resting ventricular ectopy, PVCs, and their CPVT, exercise-associated PVCs. So depending on what's going on, we may or may not need to bother trying to suppress those resting PVCs. Would the denervation work for those? Don't know. We usually don't do it for resting PVCs. Do we need to silence the resting ones? Depends on how many you're having and whether you notice them or are bothered by them. So there are rare occasions where we've taken a CPVT patient, like the control of their CPVT. They have resting PVCs from the other thing that normal people can occasionally have, and we've actually done an RVOT PVC ablation, meaning ablated those non-CPVT PVCs. A little bit complicated sounding, but in other words, there's some things to unpack. Your healthcare team should never always think that everything is coming from CPVT or everything is coming from your long QT. I had a great question from one of the teenagers in the chat, teenage only room, about describing his LQT8 and all of his chest pains, random stabbing chest pains that he's having, and why is his LQT8 heart acting up? And the reality is that has nothing to do with LQT8 or LQT2 or LQT anything or CPVT. Sometimes, quite often in teenagers, you can have random chest pains that's not even the heart muscle at all. So we always try to make everything fit into the one disease we have, but sometimes there's a separate thing that's along for the ride. Nancy, I love that question. Victoria, considering what I would consider moderate caffeine amounts, how many milligrams per day? I don't even really do milligrams. I could look it up. So I've got I love this. It's my favorite drink. Molokai coconut is my favorite one. And see, it says here, 55 milligrams caffeine per bottle, like a cup of green tea. So that's what I have. So I usually have that. And then I often will treat, now I have 2 beautiful, wonderful people who are shadowing with me for the next several months, adult heart rhythm specialists. So I have Dr. Adi Lador from formerly Jerusalem, now Houston, Texas, and Dr. Rachel Neves from Sao Paulo, Brazil, who I like to treat them with their morning Starbucks. And so I'll have a Starbucks right now, my favorite, that toasted white chocolate mocha. Ooh, that's a new one out for the season. So that's my caffeine for the day. Really, my rule of thumb is whatever caffeine you're taking, if it's giving you palpitations, that's too much caffeine. And Oh, so now there's some new votes that have come in here. I'm going to scroll up. I did that one. 3 votes. Oh, this is a great one. Jennifer, parent of LQT2 kid who's on Nadolol, first one and only one in the family. How and when does a parent ever feel comfortable leaving their child home alone and then eventually driving and then college? Do parents ever get an ICD in their teen years just so they can live more independently and worry-free? Great question. This suggests to me, Jennifer, that you guys are early in your long QT journey. I promise you, you'll get more and more comfortable and more comfortable. And no, I never do an ICD as a worry-free philosophy because it's not worry-free. If the ICD was this awesome life insurance package without complication, then yeah, but it's not. Dr. Etheridge, Dr. Knackrell, all of us have seen basically every complication under the sun that can come from ICDs. And the complication package, if you need the device, no problem, accept it. If you don't need the device, don't take it. It gets better. It gets better, and you will have the confidence to do all of those things. Just hang in there. You're early in your journey, and I promise you it'll get better. For an adult male with asymptomatic Brugada syndrome, fever provoked the ECG pattern, SCN10A variant that could potentially be pathogenic, but no history of syncope or family history. Is it safe to take ADHD stimulants that are not listed as to avoid on the Brugada Drugs website? Well, first thing, Serena, great question. This individual's at incredibly low risk for a Brugada triggered event. If the only reason we know that there's a Brugada pattern is in fever, but other times not, probably is not going to be at high risk. The SCN10A, I'm not buying. I don't know if that has any relevance at all. And so, well, this website is interesting now. Now that the votes are changing, it's just flying through. Huh, interesting, changing votes. Okay, so where did that go? So anyway, I have no problem with that person if they need ADHD stimulant therapy because they truly are struggling with ADHD, attention deficit hyperactivity disorder. I treat my patients, or I let the psychological, developmental, mental health care team do that. Michelle is asking, during this morning session, and I see I've got about 20 minutes with you guys left. So I'll see if I can be quick in my read and pithier in my responses, but these are such rich questions. You guys are awesome. Michelle saying, morning session with Dr. Etheridge stated that long QT patients can participate in sports with appropriate counseling. What are your recommendations for young children with LQT2 participating in sports other than bringing an AED along? What other? Great question. I totally agree with Dr. Etheridge, as she and others know. I think Mayo Clinic gets the credit for changing the landscape as to how we let people live despite their disease. I started my career at Mayo Clinic on staff in the year 2000. At that time, it was, if in doubt, kick them out. And at that time, throughout the world, that policy, I raised my hand and said, why have we been doing it this way? The families and the kids with long QT deserve better. We can do better. And so I believe in the athlete and their family's right to be able to make a well-informed decision. I currently follow about 700 athletes with a variety of genetic heart diseases, mostly long QT syndrome. And to date, there have been 0 deaths. There have been 0 AED rescue shocks. So do I require my athletes to have their AED as their safety gear? Absolutely. Do I expect it to ever get used? Nope, I don't think it's going to get used, but as part of the safety plan. Might there someday be a during sport tragedy? Of course. I can't make the risk 0, but every family has to weigh in the balance a non-zero risk scenario and what they're encountering in their child where oxygen got taken away from them. Now, If that sport is O optional and not O oxygen, then why do something that's optional, that's not risk free? But when that sport or activity is O oxygen or close to oxygen, I totally think we can keep that sport activity in play and do it well and do it safely and live and thrive. And so I really was glad that Dr. Etheridge said that during the lecture. Monica, what options are available for families whose teenager died from sudden cardiac arrest when genetic tests finds nothing? And first, I'm so sorry, Monica, for your family's loss. Part of it depends on what was done in the investigation for your teenager. Hopefully, there was a good quality autopsy performed that showed that there was or wasn't anything there that the eye or the microscope could detect. Hopefully, your family received the counseling that all of those teenagers, that tragic death, their siblings and their mother and father got carefully evaluated by a good cardiologist with standard tests. If still nothing has emerged or is showing, and the genetic test was done and was negative, we can do research-based genetic testing, and we've offered that here at our place. We call it the whole genome trio, where we do a gene sequence of the entire genome in the deceased and their mother and father, and we do a comparative genome analysis. I say we do that, but the answer is, the honest answer is, when you've come to a place where the medical examiner can find no reason, there's nothing in the living relatives to note, the standard clinical molecular autopsy that you can do through Invitae, Ambry Genetics, and so forth reveal nothing. The real answer is we almost never find something with the genome trio. The only silver lining in what I just said with that is when nothing is found, tragedy basically never strikes again. And that has been something that's been the only encouraging silver lining to what is an incomprehensible tragedy for families like yours. So I just extend to you my deepest sympathies with what you and your family are going through. Imran, am I aware of targeted therapies for CPVT1 for RYR2 mutations? Do I think this could be a viable alternative approach if successfully developed? Yes, I'm aware. There's more than one company. There's one company, full disclosure, I consult with them, is Armgo Pharma, ARMGO Pharma. You can follow along their development story. They're working on a targeted therapy for CPVT1. It's early, it's still in preclinical trials. So I do think there's a variety of strategies that give hope to directly target the consequences of the RYR2 defect and counterattack it or neutralize it. Beta blockers do nothing to the RYR2 mutation, but it's good therapy for CPVT. Flecainide does nothing to the RYR2 mutation directly. It just counters the abnormal signaling sequelae that gets set up by the mutation, that leakage of sodium current for which the flecainide then counters that increased sodium current that Dr. Etheridge talked about. But something that's more proximal, that's directly targeting the immediate perturbation that the ryanodine receptor mutation is doing to the performance of the ryanodine receptor. Those strategies are underway. They're moving quickly from animal pre-human studies to first in-person clinical trials, so stay tuned. Jasmine's asking, what efforts are being made to disseminate information to patients and medical professionals to ensure that those who cannot go to Mayo Clinic, for example, can get proper treatment? Great question, Jasmine. That answer is www.stopsads.org, the SADS Foundation. The SADS Foundation provides tremendous amount of information. Check us out at that website. The PACES organization, Pediatric and Adult Congenital EP Society has materials. Um, there's a Mayo Clinic Connect Care. I don't have the website, but where we have posted lots of information for patients, families throughout the globe, and caregivers. So, and those who also cannot get to places like Mayo Clinic, one of the things that COVID-19 pandemic has done, and it's forever changed medicine, is telemedicine. Every day now, I will see one patient in the room and then go to my other room, the video camera, and I'll have a video consult with somebody somewhere on the globe. And so we will be doing, and many places are doing, telemedicine, and that's going to connect us all even more, where we may not, for certain situations, need to physically be on that campus, unless, of course, we need to be on that campus to get that intervention, that denervation or whatever. So SADS Foundation, they've done a great job. For those with ARVC, the ARVC website has done a great job. For those with hypertrophic cardiomyopathy, the HCMA organization has done a great job. So I think the efforts have been impressive by all of these nonprofit advocacy organizations. Great question, Jasmine. Is having a de novo, Jennifer asks, is having a de novo diagnosis of LQT2 more serious or mean they're more susceptible? No, it doesn't. It just means that that's new in you and it started in you. And so therefore we won't have any sense of how it's behaved in other people's bodies. Even though family history is not a true personal risk factor, you still start to get a sense of how is that mutation behaving in other relatives who have more similar genetic backgrounds than non-relatives. And so you get a feel of what's been the spectrum of behavior. When it's a new in you mutation, there's no other informants. And so, no, it just means that we're studying its profile, assessing its risk in you and you alone. How common, Lori's, how common are misdiagnoses of CPVT and long QT? Common, unfortunately. The delay in diagnosis of CPVT is unacceptable. John G. DeCessi from our program published it. It can average months to years from first symptom of concern to correct diagnosis of CPVT, with that lag time often being because that CPVT person had been labeled as epilepsy, treated for epilepsy, spells continuing to happen, and then finally the neurology people started to think about the organ south of the brain. So exercise-induced generalized seizures must be evaluated by a heart doctor as well as a brain doctor. These misdiagnoses continue in 2020, and it's unacceptable. We're doing better, I think, but it's not unusual to have the misdiagnosis of the week in our program, of the week. Not to mention that we have now about 1,000 patients who came to Mayo Clinic with the diagnosis of long QT syndrome, who left Mayo Clinic without the diagnosis of long QT syndrome, with almost all of those 1,000 being dismissed as normal. So not only are we still missing the diagnosis when it's there, we are overdiagnosing these conditions in people when it's not there. So work to be done. We're making progress out there. Still happens. If in doubt, get a second opinion somewhere. Alexis, 10 minutes on the counter. Wow. For those patients with a rare genetic type, say LQT5, how do we find out now whether our mutation is truly disease causing? My mutation is classified as likely disease causing by GeneDx. Wow, Alexis, great question. We've seen a genetic reclassification because of knowledge. That's the exciting thing, where people need to realize that genetic test results are fluid potentially, that there is going to be some shift, the LQT1, LQT2, LQT3 genes, they will never get demoted. They are, take it to the bank, long QT susceptibility genes. Many of the other minor ones, including those discovered in my lab, are maybe long QT susceptibility genes. Some of them for sure are, and we just need more knowledge to prove it. Others are not so fast. You mentioned LQT5. LQT6, for example, has been fully demoted to not buying it, maybe not even a disease gene. LQT5 is a true disease gene, no doubt about it. But every variant in the LQT5 gene, KCNE1, is not. And so it really brings us back to what's your story? What's the strength of the evidence from your ECG? What's the strength of evidence in your story? How long QT suspicious is it? And your doctor, like any good doctor, should constantly be reviewing the strength of the evidence and say, I don't care what that January paper said. I still know that you have long QT. You look like long QT. You act like long QT. You're long QT. Jan's asking, Tara, my daughter, is newly diagnosed with genetic LQT1. She's a swimmer. So there's a connection. And she takes albuterol derivative and just started on a very low dose of propranolol. How will we know when she reaches a correct dose for it? So again, I think a couple things. First, swimming in LQT1 has been viewed as oil and water, doesn't mix. Don't do both. I'm not sure about that. Sure, certainly swimming is probably more LQT1 irritating than other dry land aerobic activities, but I have several LQT1 swimmers when I've been confident and pleased with their treatment program, and swimming is their oxygen. We have kept swimming in play. But I have to be pleased with their therapy. I have to view that I have them on a good dose of beta blocker with good effect on their stress test. And if I'm not confident, we are moving that patient over towards additional denervation protection, because denervation surgery works absolutely the best in LQT1 and CPVT, and then in LQT2, and then LQT3. I'm still not convinced just how good it is in LQT3, but its protective effect, its risk reducing effect is no doubt about it. If it's done right, that's important. I could tell you a story of last week's third time denervation where St. Elsewhere did it wrong the first two times. But if it's done correctly and the appropriate chain has been appropriately removed, the antifibrillatory effect for LQT1 is really, really good. We talked about that. Rachel's asking, is it unusual to have PVCs by Gemini during bradycardia and CPVT? It's a bit unusual. Concern, no. I'd want to know, are you CPVT mutation positive? To know that I have the correct diagnosis. Could it be one of those 2-for-1 specials like we mentioned, where you have a separate sort of benign ambulatory PVCs? Could it be a bit of a mimicker of CPVT? Every once in a while, we've seen tomorrow's program by the Johns Hopkins program and Hugh Calkins of ARVC sneaking in and mimicking CPVT a little bit. Bernadette is asking, oh, where did that go? Long LQT2 was reported in uncle, confirmed with a genetic test. My mother, meaning the uncle's sister, and I have tested negative. My mother, me, and my daughter have long QT abnormalities in the ECG. Oh boy, goodness, this is getting complicated. Is our long QT symptomatology, even without genetic evidence, more related to my uncle's Or is it more that the negative genetic finding suggests another certain genetic element? Great question, Bernadette. Everything comes down to the story. So let's say your uncle truly has long QT syndrome by the ECG, by story, and it's proven to be due to LQT2. Great. Let's say your mother, his sister, truly does not have brother's LQT2 mutation, but has long QT from the ECG, and so do you, and so forth. Uncommon, but I've absolutely seen it, where you can have two separate reasons for long QT syndrome running through the family tree. So when there's a discordance, as in you're showing it, but you're not having uncle's thing, we need to now start over with your mom and you and do independent LQTS genetic testing to see if there's a possibility that you might have, your mom and you might have long QT syndrome for a different genetic reason than your mother's brother. Have seen it many, many times. It's not common, but it definitely can happen. My clock is running out. I've got 3 minutes before we shift over, and I hope people are going to be able to shift over to StreamYard for the volunteer awards, and then really exciting Pioneer Scientist Awards. So let me see. Did that one. Hans, Peter, are there any drugs one should avoid with CPVT? No, basically no. QT drugs, www.crediblemeds.org, are not relevant to CPVT. Brugada drugs, www.brugadadrugs.org, are not relevant to CPVT. The only thing I would say in CPVT, drugs that are adrenaline-like are CPVT dangerous. Cocaine, not a good idea for CPVT. Amphetamine, not a good idea. Now you'd say, oh, what about Ritalin then, and Vyvanse, and Strattera, and the ADHD drugs? Yes, they're adrenaline-like. If my CPVT patient has ADHD, we have and we do treat them with their ADHD medications. And to date, there has been zero problems. I think we did the denervation. There seems to be many bad side effects of LCSD. Dana, I just say that's wrong. That's some misinformation and misrepresentation from Google. So you have to understand that those who have loved their denervation, they're out running, playing, jumping. They're not back on the website telling about their horrific neuropathic pain. So I think the internet in that setting tends to then create a unbalanced shift of that 5 to 10%. I'm not sugarcoating that 5 to 10%. We're bothered by it. We're trying to make that as low as we can, but the internet creates this many bad side effects when most of our denervation patients are really pleased about their denervation, and they would take their denervated existence over how they felt with either their disease shocking them all the time, or their defibrillator, or having been a beta blocker zombie, and for the first time, life has come back to them because they don't feel that way any longer. So I think it's better than certainly advertised. I think, wow, I think we did it, didn't we? Well, let me just stop there. And I know we probably have more posted, and maybe on SADS Facebook Live, we will bring some of these questions up next Friday. If you don't know about SADS Facebook Live, start joining us, spread the word. We are at SADS Facebook Live number 38 next Friday. And so every Friday now, since about February, Alice and Aaron and team have put on SADS Facebook Live programs. Some of you have been interviewed. I look forward to interview some others of you over these Fridays. We have great programs, sometimes just devoted to your questions and answers for the full 40 minutes every Friday. Some like yesterday, where we interviewed the Chief Medical Officer, Dr. Robert Nussbaum of Invitae, where Invitae is the lead sponsor of our first virtual conference. So maybe come there next Friday and see what questions we can take. But I'm going to say thanks for Fireside Chat. I'm going to try to get a quick sip because I think my vocal cords are completely wiped out. But these questions, Alice, were amazing.
Amazing. Yes, thanks so much, Mike. You guys you're amazing answering all those in a row, as well as the kids, so thank you so much. And I hope everybody take a quick break with us. In 15 minutes, we're going to start the ceremony that Mike mentioned for our awardees and our special pioneer scientists. So everybody has a minute to take a break, chat on the Who app, and we'll see you in 15 minutes.